Today I'm going to talk about bleeding disorders. So this will be my outline. I've talked about basic understanding of bleeding, how do we approach, how do we assess, and I will end with 6 different scenarios. So when understanding in terms of the basic of bleeding, we need to know a few things in our mind. First is in terms of the mechanism. There's 2 mechanisms involving primary and secondary hemostasis. There's 3 key players involved, which is a platelet, von Willebrand factor, and clotting factor. And they are different in terms of whether you're talking about quality or quantity, and you're talking about whether it's inherited condition or it's an acquired condition. So other than that, you're talking also about forces, be it the coagulation pathway together with the anticoagulation effect, and you're talking about impaired fibrinolysis and possibility of third forces, which is the complement system. So when we talk about primary hemostasis, perhaps when a vessel get injured, for example a vena puncture, the first thing that is get activated is not the platelet. Instead, it is the vascular spasm of that particular region. So this vascular spasm is induced by endothelin, and it causes 2 different pathway which actually promotes calcium influx into the smooth muscle, as well as promoting the muscle actin fiber formation, and this induces vascular spasm and contraction. So on top of that, there's also neural reflex being involved. The sympathetic activation will actually release the neurotransmitter, and that will also potentiate the vessel constriction. Following a vascular spasm, here comes the role of the platelet. So as you see here, this is a structure of a normal platelet. There is alpha granule and as well as dense granule. You can see that alpha granule actually have factor 5, factor 8, fibrinogen, fibronectin. Dense granule actually have ADP, calcium, and serotonin. So why does it matter? So when the platelet gets activated after the vascular spasm, the 3 main process happen, which is the adhesion, activation, and aggregation. So what happens in the adhesion is that you can see when there is an endothelial collagen being exposed in the vessel, in the blood, so it actually promotes the binding of the von Willebrand factor as well as the platelet surface receptor glycoprotein 1b. So these 3 will actually form a strong connection, and then this will actually triggers the activation process of the platelet. You can see that this is a normal structure of platelet. What happened is the ADP will start to release from the dense granule, and then which actually promotes further binding to the receptor among each platelet, and because of the calcium influx and the kinase phosphorylation, the cytoskeleton will get rearranged, and you can see that platelet from the round structure will become spiky. Okay, and this is a unique structure. It's an effective structure of the platelet to actually stop the bleeding. So what happened next is that the aggregation process happened, in which the fibrinogen released by the alpha granules as well as the surrounding platelets will actually bind to the surfaces through the glycoprotein 2b and 3a, and then this further amplified the whole process of aggregation among platelets. You can see they are forming a colony, and then they are stuck together in this breakage of the vessel. So what can go wrong after understanding platelet as well as the vascular spasm issue? So let's say you have a vascular defect, for example endothelial dysfunction, subendothelial defect, for example Ehlers-Danlos, Marfan syndrome, or those hyperelasticity syndrome, or you can get acquired injuries, for example burns or radiation. So what happened next is actually, if let's say you're talking about platelet defect, meaning in terms of the quantity, you're talking about thrombocytopenia. What actually causes a thrombocytopenia? It can be due to reduced production, increased destruction or sequestration, or you're talking about qualitative platelet defect, which actually involve adhesion, activation, and aggregation process that we mentioned. So different condition will actually predispose to different phase of the platelet defect. You're talking about, if let's say it's glycoprotein 1b, you're talking about Bernard-Schroeder syndrome, glycoprotein 2b, 3a, you're talking about Grasman thromboasthenia, and you're talking about activation process, you are talking about aspirin as well as the clopidogrel defect. And this is more to acquired because of the drug. And you're talking about aggregation defect, then it's more to the abnormal granules, okay, or even defective in cytoskeleton structure. So the second component which is important in primary hemostasis is actually the von Willebrand factor. So as you can see from the diagram, this is extracted from NEJM. So as soon as the one ribbon actually being produced from the Golgi apparatus, it will actually form this variable pellet body. This variable pellet body will actually release the one ribbon strain outside circulation and subsequently cleaved by the enzyme called ADAMTS13. So initially, the single strain of this one ribbon factor is actually a very huge monomer, which subsequently cleave into multimers. Okay, and the two main essential function of the one ribbon factor is to facilitate the pellet binding to the subendothelial collagen, as what we mentioned, be it a glycoprotein 1b or 2b3a. At the same time, it also protects against the clotting factor A to become consumed. So this is the two most important function of the one ribbon factor, and deficiency in one ribbon factor can be inherited or acquired. So this is again just to illustrate the diagram that one ribbon factor actually facilitate the binding in terms of the activation of pellet as well as aggregation. So when we talk about one ribbon disease, it can be hereditary or what we call as inherited, or you're talking about acquired. So how do you remember all these different types of one ribbon disease? It's difficult, right? But to cut the story short, actually, if you're talking about essentially there's only three types. You're talking about quantity issue, then you're talking about type 1. If it's a quality issue, then it's type 2. And you're talking about both quality and quantity is affected, which is virtually absent, one ribbon factor, then you're talking about type 3. So you can see that different phenotypes of the one ribbon disease will have different manifestation. This is very illustrative. But how do you remember is that type 1 is basically you can make it, but it's not enough. Okay, and one of the type 1 subtype is called 1C. If you clear too fast clearance, this is called 1C. So type 2 is you're dealing with the quality. If 2A, you're talking about abnormal multimers, it produces a lot of abnormal multimers. B is it binds to the pellet. Okay, M is actually have a lot of multimers. Okay, and N is actually no factor A. This is the one that when we check, let's say patient have one ribbon disease and you check the factor A is also low, very low, almost absent, then you are talking about 2N. Okay, but let's say type 3 is basically you don't make it at all. So there's also an entity called acquired one ribbon syndrome. So acquired is something definitely not congenital, it acquired from other things. For example, you're talking about mechanically circulatory device like putting a patient to ECMO or left ventricular assist device. That can actually cause acquired one ribbon syndrome due to the shear force through the machine. At the same time, some other conditions, for example, myeloproliferative diseases, myeloma diseases, that can also predispose to one ribbon disease. It's also interesting to take note that if let's say anyone that have thrombocytosis, be it reactive or primary thrombocytosis, in which the platelet more than 100, there is a risk to actually leads to acquired one ribbon factor syndrome as well. Okay, and the last but not least, there's this condition called Hailey syndrome, in which patient has severe aortic stenosis, angiodysplasia of the colon, at the same time also predisposed to bleeding due to this condition also producing acquired one ribbon syndrome. So now comes to secondary hemostasis. Secondary hemostasis, the important thing we need to understand is the coagulation cascade. To cut the story short, when you talk about intrinsic pathway, it's not just factor alone. You are also talking about contact factor activation, which is the kallikrein, kininogen, and also bradykinin pathway. And you're also talking about factor 12, 11, 10, as well as 9 and 10. So all these are considered intrinsic pathway, and it can be detected through the activity from the ABTD level. And if you're talking about extrinsic pathway, you're talking about a tissue factor as well as a factor 7, and then a factor 2, which is factor 2, which is a tissue factor, and factor 7, and they both of them join together with the factor 10, and generally after factor 10 is your prothrombin to thrombin and fibrillation to fibrin. These are all common pathway. Okay, so involve factor 10, factor 5, factor 2, factor 1, as well as a factor 13. Okay, to further stabilize the clot. So when we talk about anticoagulation pathway, you're talking about body intrinsic anticoagulation mechanism. When the clot form, ideally the rest of the body, the rest of the part of the body that's not injured should not have any clot. Okay, so this is the body natural mechanism to prevent the blood from unnecessarily clotting. So based on the coagulation cascade, you can see that there's mainly three components that's involved. First is antithrombin, which actually inhibits the thrombin as well as the factor 10. And the second is a tissue factor direct inhibition with a pathway inhibition. by inhibiting the tissue factor and the factor 7 complex. And the third possibility is the reaction between protein C with thrombomodulin with the cofactor of protein S. This actually activated the protein C, and this will actually leads to inhibition to the factor 5 and also factor 8 mainly. Okay, so when you talk about fibrinolysis pathway, you're talking about plasminogen being activated to plasmin, which actually resolve the fibrin into fibrin degradation product. So this is also a body natural mechanism to kind of like lyse the fibrin. Okay, so fibrinolysis is actually a process. It's a process and a balance between activation and also inhibition. When there is activation, for example, plasminogen activator, for example, either it's a tissue or urokinase activator, this will actually activates the formation of plasmin and further causing degradation of fibrin. When talking about inhibition, there's mainly two, which is a direct inhibitor from the pellet plasminogen activator inhibitor, which mentioned here, which inhibit these two, or alpha-2 antiplasmin directly inactivate the plasmin, or indirect method through the thrombin activable fibrinolysis inhibitor. Okay, so this will also inhibit the degradation from fibrin to fibrinogen. So after having understand this is just an overview to actually combine everything that we have learned and also recap so far in a general diagram. So after understanding the coagulation, the anticoagulation and fibrinolysis, perhaps we will start to realize that what can go wrong. Let's say a patient having bleeding. So the first thing is perhaps in the coagulation pathway, the patient does not have enough clotting factor as well as contact activator. If let's say the contact activator talking about prekallikrein or this high molecular weight kininogen, which is usually have a very mild form of bleeding. But the main part of this coagulation cascade issue is the factor deficiency, be it acquired, inhibit, or inherited. The commonest is still being factor 8, which is a hemophilia A, factor 9 hemophilia B, factor 11 is hemophilia C, and factor anti-vitamin K antagonist, which is a warfarin that inhibit the vitamin K dependent clotting factor. You also got factor 10 inhibitor, for example, apizaban, rilozaban, itozaban. They generally inhibits the factor 10 as well. So that can predispose patient to bleeding because of the activation of the coagulation. And the second possibility is actually increase in the body intrinsic anticoagulation activity. So the example will be the direct and indirect antithrombin activation, which is direct one, you're talking about dabigatran or the intravenous form like argatroban, bivalirudin, or hirudin. Indirect one is the heparin and also the fondaparinux. Okay, if you are talking about activation of the fibrinolysis, then you're talking of the increase in the activation and reduction in the inhibition. So if you're talking about increase in the activation, perhaps drugs like, for example, streptokinase, alteplase, the nectarplase, which actually involve tissue, that can actually predispose patient to bleeding, right? The one that we use for stroke, also in ACS, in the STEMI. And let's say the catheter is being clogged out, you want to give urokinase, that's also try to promote the fibrinolysis. Reduction in inhibition generally can be seen in patients that have sepsis and also DIVC. How about the third force after knowing coagulation, fibrinolysis? So perhaps now there's increasing evidence showing that our complement pathway, be it a classical leptin or even alternative pathway, actually indirectly contributes and interlink between the coagulation pathway as well as anticoagulation pathway and fibrinolysis. So the factor H seems to be the mediator of everything, and we can see that nowadays there is emerging factor 8 inhibition inhibitors that is still on clinical trials, and then there's also a lot of studies going on, especially in TTP and also atypical thrombotic microangiopathy, which is the atypical HUS. So you can see that complement, coagulation, and fibrinolysis actually they are very complex mechanism that happen in our body, and it can actually interact with each other. Okay, so now back to the question of how do we approach a bleeding patient. So first we should start off with a good history and examination. Second is to actually try to stage the severity, and then we'll investigate further and confirm our diagnosis, and subsequently we manage the patient. So when we talk about history, you're talking about bleeding history in particularly. You want to know the onset, whether this is the first bleeding or recurrent bleeding, whether this is spontaneous or traumatic bleeding, and what is the site involved. Let's say you are dealing with primary hemostasis issue, patient commonly presented with mucocutaneous bleeding, meaning it's a mouth or oral cavity or any form of skin, bruises, and or even any bleeding post hemostatic challenge, for example any surgery, any dental extraction, any for example postpartum period. So you're talking about secondary hemostasis, it usually involve deep tissue bleeding, can be joint, can be musculoskeletal, okay, or can be soft tissue as well. So all these are a general cut-off. Sometimes a patient that have presented with bleeding can have both, okay. So generally this is just a general idea, and it's also important for us to screen for all orifices, including nose, lung, ears, gut, urine, or even vagina, okay, to look for any form of bleeding at all. And the next thing is perhaps the family history. We want to know whether this is something to do with hereditary condition as well as some association. So at the same time, we also need to know whether patient was previously transfused, what is the patient recent vaccination, what is the traveling history, predisposed patient to some tropical diseases, and whether there's any high risk behavior. And in terms of past medical history, it's important to know whether patient got any liver or renal disease, malignancy, infection, or autoimmune disease. And for drug history, we need to know whether patient is on any blood thinners or even sometimes any form of painkillers, especially NSAID. And dietary history is important, whether we want to know that patient is having any vitamin K or C deficiency. In terms of examination, it is also important to look for clues to suggest either mucocutaneous or deep tissue bleeding. In mucocutaneous bleeding, you are expected to find a petechiae, purpura, ecchymosis, like skin or even skin necrosis in a severe case. So a common example will be dengue. Dengue usually present with thrombocytopenia in the critical phase, and that is the point that you will notice there's a lot of petechiae. So how about deep tissue bleeding? Deep tissue bleeding, you are particularly of concern in terms of any hematosis, any soft tissue or muscle bleeding. And at this point of time, it's also important to examine for any hepatosplenomegaly to exclude any form of myeloproliferative disorders, and can it be some form of malignancy, hematological related malignancy. And we also need to look out any stigmata of systemic disease, be it chronic liver disease, renal disease, connective tissue disease, malignancy, especially want to palpate for any lymph nodes, and telangiectasia in a hereditary condition. So how do we objective score a bleeding patient? There's a few scoring system available, and the one that we are commonly using will be the ISTH BAT score. You can see the ISTH BAT score actually have a very high specificity of 99%, and it's also quite sensitive, 84%. And generally, this questionnaire can be initiated in 10 to 20 minutes depending on your familiarity. So this is just a rough calculation. You can see that this is a you won't get this online readily, but generally how do we know it's abnormal is when in children the score is 3 or more, in the adult man is 4 or more, or in a lady is a 6 or more. So you know that this is actually serious if let's say it's more than this score. And to categorize it in a simple manner, you are talking about spontaneous bleeding versus post-hemostatic bleeding. So it can from the top to bottom, it can actually consist of intracranial bleeding, epistaxis, oral cavity bleeding, bruises, bleeding from the wounds, muscle, joint, gut, or vagina like menorrhagia, or even from the urinary tract like hematuria. And post-hemostatic challenge, you're talking about tooth extraction, postpartum, and also surgery. Okay, so this is just I would say an ideal way to work out the patient when you're talking about if you're having any patient that have bleeding. You want to try to work from the point of whether you're dealing with primary hemostasis or secondary hemostasis, or even you're talking about fibrinolysis activation. So this is very, I would say, very academic, but in terms of practicality, perhaps it's not very useful. So how do I approach a bleeding patient? So generally in a clinical setting, this is to me is more practical. First, we want to differentiate that you are dealing with whether this is a platelet disorder or coagulopathy, or you're dealing with both. Okay, so let's say you're dealing with platelet disorder, you're dealing with thrombocytopenia, which is the quantitative issue, or you're dealing with qualitative platelet disorder. If you're talking about thrombocytopenia, the most useful clue perhaps is to get a urgent PBF. That will tell you a lot. Okay, and if you're talking about platelet it seems to be normal or near normal value, but patient having bleeding and the coagulation profile is normal, perhaps you want to screen for systemic disease that can predispose to platelet dysfunction, for example uremia, or for example liver cirrhosis. And you also want to consider whether you're dealing with von Willebrand factor disease. Therefore, you may need to order a von Willebrand assay, whether it's the quantitative measure of the factor level or is a activity level. Okay, and then if you are looking at coagulopathy with a normal platelet, then you have to really look at whether which part of the coagulation profile is abnormal. If it's isolated prolonged APTT or PT, commonly APTT, then the next step you need to proceed is the missing study, followed by factor level and also Bethesda assay to look for inhibitors. At the same time, it's also worth pointing that you want to check for whether there's any evidence of APLS. Okay, but let's say you're dealing with both APT and PTs prolonged and also there's thrombocytopenia. The first two diagnoses that you must think of is actually any liver disease or even suspecting DIBC. Okay, so this is my very simple way of approaching for a patient with thrombocytopenia. Generally, any platelet less than 150, we will classify them as thrombocytopenia. So how do we further divide? To me, I will look at the patient, I will decide that whether it's sick or not sick, okay? And I will look at the platelet count, whether it's like less than 10 or it's ranging between 10 to 120, okay? Because this will tell us a lot of things. Let's say you're talking about a patient that is not sick, and then you're talking about just borderline low platelet, which actually have no clinical bleeding. So the common differential diagnosis will be first perhaps a pseudo thrombocytopenia. Therefore, PBS is important, and also you may want to send the sample in a citrate bottle. Gestational thrombocytopenia, drug-induced thrombocytopenia, nutrition deficiency, or even hereditary thrombocytopenia. Okay, but let's say you're talking about platelet that's less than 10 or even less than 50 to begin with, then you need to suspect hard for whether this can be immune thrombocytopenia or ITP, whether this can be drug-induced thrombocytopenia as well, and whether this can be post-transfusion purpura. Okay, generally they are very low platelet, but they appears quite well. Okay, and if you're talking about sick patient with a borderline low platelet, you also need to suspect whether this is an early form of DIBC, this is HELLP syndrome, this is a thrombotic microangiopathy, be it DTP or HUS, whether you are dealing with severe sepsis with increased consumption, whether you are dealing with liver disease or evidence of hypersplenism for any cause. If the patient is sick and the platelet is low, this kind of patient you really need to watch out, because it can have very serious infection going on, for example severe sepsis. It can also have HLH, can be TMA, can be aplastic anemia, and in patient with SLE or even any rheumatological condition, let's say there's evidence of IHA, then you're suspecting that can this be Evans syndrome. Okay, but bear in mind that regardless what level of platelet, in our country, dengue is still first thing to exclude. Okay, we cannot afford to miss any dengue that turn out to be very ill, and we take a combo test, turn out to be positive later on. So this is something we have to keep at the back of our mind. So I have mentioned that we need to take a PBF urgently when we're dealing with thrombocytopenia. So the important point is that you need to look hard for any evidence of platelet clumping, which will actually suggest of pseudo thrombocytopenia or artificial thrombocytopenia due to EDTA interaction. If it's a true thrombocytopenia, you want to look hard for whether there's any features to suggest hereditary thrombocytopenia, in which there will be presence of giant platelets and also white cell inclusion. You'll talk about it later as well. So let's say you have excluded these two. The few things onwards is important. We want to look hard for any features of cystocyte that will suggest hemolysis, and this will generally leads to diagnosis of TTP or HUS or DIBC. Okay, and therefore the hemolytic markers is the way forward. And if you find there's abnormality into the white cell, in particular there's blast, there's nucleated RBC, there's pseudo or even page-weight anomalies, then you're thinking about primary marrow disorders, be it the MDS, MPM, or even leukemia. Then the next thing going forward is actually the marrow. Okay, if let's say you found out that there is a RBC clumping or agglutination, which actually suggests IHA, then you need to consider Evans syndrome, and therefore again you also want to check for the Coombs test. Okay, this one will be Coombs test negative, this one will be Coombs test positive. Both have points to suggest hemolysis. And let's say you found a PBF that is more reactive picture, meaning to say it's more like got atypical lymphocyte, got a lot of toxic granulation, got left shift, got lymphocytosis. So all those are very infective kind of nature. You want to actually proceed with your infective parameters. And next is, if you cannot find anything else, for example, this is an isolated thrombocytopenia, then perhaps the remaining differential would actually eventually leads to screening of systemic diseases and as well as bone marrow after that. So artificial thrombocytopenia is the condition that usually happens because of the EDTA tube, because of the antibody that is directed against the platelet antigen, glycoprotein 2B and 3A. This antibody generally only expressed in the presence of EDTA. Okay. However, bear in mind that up to 17%, even if you repeat the FBC under the citrate bottle, it may be uncorrected. And one of the reasons is being of the longer delay while sending the sample to the lab. This is how it looks like when there is a platelet clumping under the PBF. So there's also another way to assess the marrow function by looking at the mean platelet volume, immature platelet function. However, it's generally not available in most of the lab. Okay, but generally it's just like an analogy of reticulocyte. If it's raised, then it suggests that the marrow is functioning. If it's low, then it means that something is happening in the marrow. So, but generally we still need the bone marrow aspiration to find. Let's say we suspect it's a marrow issue. Okay, next thing is I want to talk is actually about the platelet threshold count. This one is extracted from the Blood Project website. It's actually very important for us to know that when we want to do any procedure, especially for diagnostic procedure in patient with low platelet, what is the level that we are aiming for before the procedure. So let's say there's it's an eye surgery or brain surgery, you're talking about platelet more than 100. Epidural surgery, epidural procedure, okay, you're talking about 80. And lumbar puncture or non-neuroaxial surgery, you're talking about more than 50. And then central line insertion, more than 20. And generally anything less than 10, we want to go for procedure should actually cover with platelet transfusion, okay, because of the bleeding risk, okay. And another thing to highlight is that you can see that the platelet normal range is 150 to 400. Generally, if the platelet shoot up to more than 1000, actually there's paradoxical risk of bleeding because of the acquired von Willebrand disease. This is something that I've mentioned just now as well. So next is the isolated prolonged APTT. How should we approach? So when we encounter a patient with isolated prolonged APTT, so the next thing important is actually to do a mixing study. Okay, mixing study will tells you that whether you're dealing with a factor deficiency or you're dealing with presence of the inhibitors. Okay, so if let's say you are mixing a normal plasma with the patient plasma, and if let's say the APTT is corrected, then most likely you're dealing with factor deficiency. It can be hemophilia A, B, or C. And most of the time, patient will have some form of bleeding. Let's say patient don't have bleeding, perhaps you're thinking of the less common factor, which is the factor 12, or even contact factor deficiency. Okay, let's say the APTT mixing study is uncorrected. The next thing is to look at is whether this uncorrection is actually whether it's time dependent or it's a non-specific prolongation. If it's a time dependent prolongation, usually it will suggest a factor inhibition, the presence of a factor inhibition, and the patient can bleed very significantly. The commonest is actually being factor 8 inhibitors. Okay, how do we confirm? We can generally see the activity assay, which will show reduction, and we do the Bethesda assay, in which we are able to detect the presence of the inhibitor, which is expressed in the Bethesda unit. And let's say you are encountered with a non-specific inhibition, you're talking more of antiphospholipid syndrome. Okay, so a certain condition in a certain subtype in antiphospholipid syndrome can actually predispose to bleeding. We know that antiphospholipid syndrome is actually pro-thrombotic, multiple thrombosis, but at the same time they also predispose to bleeding. Let's say it associated with factor 2 deficiency, okay, which is a condition called LASH. Okay, and let's say the antiphospholipid syndrome is positive, then you got a diagnosis of APRS. But let's say it's negative, most of the time can be due to non-specific inhibitors present in the case of severe sepsis, and the inhibitor may be there for some time temporarily, and then it may wear off subsequently. So this is another diagram that is useful, especially when we approach any bleeding patient. If we look at patient platelet and coagulation profile, mainly APTT and PT, then you should able to tell you that which diagnosis that you're dealing with. Let's say you're dealing with isolated prolonged PT with a normal APTT and pellet. Perhaps the most obvious thing perhaps the most obvious thing is the warfarin use or vitamin K deficiency. It can be direct factor 10 like apisaban, rivaroxaban deficiency. It can be some early liver disease or early form of DIVC or sepsis going on. Let's say it's isolated prolonged APTT. We have discussed just now. Follow the approach by proceeding with missing study. Let's say you're dealing with both APTT and PT is prolonged, but the pellet is normal. So you're dealing with coagulation issue with a normal pellet. So it can be due to medication induced, for example, warfarin or super warfarin use, vitamin K deficiency, liver disease, acquired factor 10 deficiency in amyloidosis, which is rare. If you are dealing with a prolonged APTT, PT, as well as low pellet, like what I mentioned, then the two important things that you want to suspect is whether you are dealing with cirrhosis or DIVC. Let's say you're dealing with pellet count that is low through thrombocytopenia, but normal coagulation profile. We have also discussed this. It's important for us to look at the PBF to decide which are the direction that we are heading to. But let's say you're dealing with everything is normal. APTT is normal, PT is normal, pellet is normal. What else can this be? It generally suggests this can be some form of pellet dysfunction due to uremia, acidosis, hypocalcemia, hypothermia, or even vascular defect. And another possibility is perhaps also a possibility of can this be some form of warm ribbon disease as well. Okay, so DIVC, I think everyone knows about that. How do we screen for that? We look at pellet, APTT, PT, fibrinogen, fibrin degradation product, D-dimer, as well as the PBS as well to look for cystocyte. And if let's say you suspect there is evidence of blast, we have to suspect APML and we need to give the ATRA without delay. So the diagnostic scoring system is based on ISTH. You can see based on pellet count, FDP, PT level as well as the fibrinogen level. Okay. So now we will proceed with 6 case scenario and I will end this short sharing session. First is actually a case of a 67 years old lady who presented with easy bruising, painless hematuria, and also some blood-stained saliva for the past 1 month. So past medical condition, she has a left breast cancer, did a mastectomy. She also have thalassemia trait, not requiring transfusion. In terms of family history, the sister passed away due to non-Hodgkin lymphoma. And in terms of baseline FBC, you can see that the HB is 10, total Y 7.2, pellet is 261, is normal. When you examine the patient upon arrival, she looks pale. There's no hepatosplenomegaly. There's also no palpable lymph nodes. So this is the FBC result that actually appeared on the first attending to the emergency. So not surprisingly, you will see the HB is on the lower side, 10, and the MCV is also very low, can be suggest of microcytic hypochromic anemia. The red cell is also very high. These three is very thalassemia trait because you can know that RBC is on the higher side, the MCV is actually low. Okay. Another thing is that looking at the RDW is also increased, but the most obvious things for this patient is pellet of 3. So this is the thing. So when we talk about thrombocytopenia, approach with patient with thrombocytopenia, after getting the history examination, assessing the severity, for example, this patient ISDS score is about 9, which is significant. And then next thing is to investigate. I have mentioned earlier, in the thrombocytopenia patient, the most important test is actually the PBF. However, let's go through the rest of the test. Coagulation profile is normal, liver function normal, no evidence of hemolysis. So the PBS is the next forward. Okay, you can see that this is the PBF and it shows that there's no blast, no abnormal lymphoid cell or dysplasia. The pellet is very reduced. However, there's occasional large and giant form seen. So this tells you that the marrow is functioning and try to compensate. You can see that there's a giant immature pellet under the peripheral film. So it means that there is increase in consumption or sequestration in the body. However, the marrow seems to be functioning. Okay, so what is the next thing moving forward? In the elderly, we are worried, can this be some form of myelodysplastic syndrome that involve a single lineage, for example pellet, that's what causing thrombocytopenia. And there's a very high chance possibility because this is something that we need to rule out instead of treating everyone as an ITP. Okay, so we did the marrow. So this is the marrow result, which actually, if we enlarge it, is adequate megakaryopoiesis with only mild dysplastic feature. There's not much of blast or anything abnormal seen. So again, because of that, the diagnosis is ITP with the underlying thalassemia. So let's proceed with case 2. This is a 76 years old lady who have a fall and sustain a closed fracture right neck of femur. It's a admission to the orthopedic ward. They are planning to do a right bipolar hemiarthroplasty, and then because of the abnormal FPC result with a PET of 53, they refer to us for further assessment. So you can see that the coagulation profile is normal, HP is borderline low, probably there's some component of iron deficiency as well here, but the most worry is actually the pellet of 53. So if you are the one that see this patient, of course you need to take history. So when we take further history, the family history seems interesting. The maternal niece and also sister also have low pellets but never have any serious bleeding in the past and not really under any proper follow-up. When assess the patient, before assess the patient, we examine the patient, there is no palpable lymph nodes, there's no hepatosplenomegaly. When you assess the patient, the ISTH batch score is actually 0. So again, if you're dealing with a case of thrombocytopenia in terms of investigation, the next important investigation is the PBF. Okay, so this is the PBF of the patient, something similar but not the actual one. So you can see that generally there's not much of pellet seen in the firm, perhaps only 3 dots here or even 4 dots. So it's a true thrombocytopenia. Okay, the pellet is hardly seen. Second thing is, look at this. These are all giant pellet. Okay, giant immature pellets, which is large. Okay, so we know that the marrow is functioning. And the third thing perhaps is the clue of this. What is this? That seems to have some inclusion in the white cell. This is what we call as dose body. Okay, so if you have this triad of true thrombocytopenia, giant pellets, and also dose body, so this is a condition as what we call as May-Hegren anomaly. Okay, or in a short, it's called hereditary thrombocytopenia. Okay, so generally this condition is quite benign. They may require tranexamic acid on PRN basis if let's say they have any form of bleeding, in which they usually preceded by infection or in an acutely unwell stage. There is increased pellet destruction on top of borderline low pellet. But generally, if you follow them out, usually they have no issue, they can live normal, and there is not much of any other hematological condition. Okay, so this is a case 3. Case 3 is interesting. Okay, 72 years old lady, you can see it's all geriatric age group, presented with lethargy, pale, easy bruising, reduced oral intake, dizziness, like a symptomatic anemia kind of picture. Also got past medical history of grave disease on carbimazole. Recently, the GP increased the dose of carbimazole from 10 mg once a day into 10 mg twice a day 3 months ago. And family history, got strong family history of thyroid, which is a goiter, but no blood disorder. And on examination, she's pale, but there's no hepatosplenomegaly, no palpable lymph nodes. So again, let's see the FPC result. So you can see that she has severe anemia with macrocytosis, and the pellet is only 80, and the white cell is like 0.8. So at the age of 72 years old, we will expect for WHO criteria, HB should be actually more than 12, but this is definitely less than 12. White cell should be more than 4, but this is definitely low, and even the ANC cannot calculate. Pellet is less than 150, in which this one is actually 80. So this patient is actually pancytopenia, not only thrombocytopenia or anemia per se. So in the patient with pancytopenia, and in particularly we are worried, especially in elderly, we should actually look hard for any evidence of hemolysis, any evidence of secondary causes. So reticulocyte is elevated, and the coagulation profile seems to be elevated, but generally if you look at the trend, it may be due to sample issue.Maybe the blood doesn't actually hit the marking line of the sample, that's why it caused this, but it's not very highly elevated. Okay, so next thing is perhaps to look at iron study. Iron store is enough, phosphate is normal, but you can see that B12 is on the lower side, borderline low, and then LDH is high, slightly elevated but not very high, and thyroid function is something expected on carbimazole. And the blood bank screening, there's no antibody detected. the Coombs test subsequently is actually negative as well. So what is the differential diagnosis at this point? So this, you are dealing with a lady with pancytopenia and just increase the dose of carbimazole. There's always a risk to for carbimazole to cause agranulocytosis or even pancytopenia in a severe case. So are we dealing with carbimazole induced pancytopenia? Second thing is, can this be B12 deficiency with a borderline vitamin B12 level? Possible as well. That can also explain the pancytopenia. Or because of the age, we also need to suspect that can this be some form of hematological malignancy. So after everything workout seems to be fine, then the next thing, again, if you follow the approach of thrombocytopenia, again, the next approach is the PBF. So the urgent PBF shows actually there's occasional blast-like cell and myelocyte. This is what we call leukoerythroblastic picture. With that, definitely urgent bone marrow aspirate and trypsin is indicated. So we have done the bone marrow. You can see that generally there's a blast cell which is increased about 20%, but overall it's actually less than 20%. Okay, and then the general feature, all the mutation is negative. General feature is actually suggesting of myelodysplastic syndrome with excess blast. So the patient actually have a MDS. Okay, so case 4, perhaps in adult we will hardly encounter this, but as a referral team, if we ever go through any hematological rotation, this is a case that is quite interesting. It also teaches on how to manage this kind of patient. So you have this 56 years old lady with a weight of 53 kg. It was referred from ENT clinic. They are planning to remove the right granuloma inside the ear. So further history, she have the concern by the NS team was she have a known case of von Willebrand disease, but don't know which type. Diagnosed at the age of 15 years old during the teenage period, when she went for dental extraction and subsequently have a prolonged bleeding require factor VIII infusion. So that was the time that she was diagnosed. Very eventful. Furthermore, she doesn't have any minor bleeding, let's say going through any minor surgery or minor procedure like dental scaling. Just need a bit of tranexamic acid. Her menses was normal, there's no menorrhagia. She is para 2. The first delivery actually needed plasma product, and the second delivery needed both factor VIII infusion as well as the back cell transfusion, and also she also suffered for postpartum hemorrhage. Otherwise, there's no family history of bleeding or not known to have any von Willebrand disease. So based on this, perhaps after you get the further history, you examine the patient, nothing significant, no bruises, and then you want to stage the patient, you want to assess the severity. So patient actually have an ISTH BAT score of 8, which is significant, 6 or more, right? So oral cavity, tooth extraction, and also PPH. So perhaps it's important for us to try to trace back the result upon diagnosis at the age of 15 years old. So we managed to trace back the patient result way back to 2002, and this is the first von Willebrand study that she underwent. Okay, that's the benefit of having an EMR. So you can see that probably it's difficult to interpret, but you can see that the APTT is normal. Okay, and then the antigen, which is the what we call as a quantitative measure of the von Willebrand factor, is low, 34, and then the risk-setting cofactor, which is the activity level, is actually low as well. But if you look at the ratio, it's actually more than 1. So what does more than 1 suggest? We will talk about it later. And the factor VIII, we always want to check factor VIII together with von Willebrand factor because we want to know their relationship and which type we are dealing with. So in this patient, the factor VIII is also low. You can see factor VIII level is also low at 59. So how do we classify a patient with von Willebrand disease? So this is a very simple diagnostic algorithm. Let's say if you look at the von Willebrand factor antigen level as the first part of screening, if the level is very high, more than 50, you basically already excluded von Willebrand disease. Let's say it's between 30 to 50 and there's no bleeding, basically you cannot diagnose. But let's say patient have bleeding, like in this patient, you need to proceed further. Okay. If let's say patient von Willebrand factor is less than 30, definitely you need to proceed further as well. And what is the next step is to check the ratio. So you are checking the ratio of the activity level versus the antigen, which is the quantitative measure of it. So you are basically measuring the quality versus the quantity ratio. So let's say your level, for example, in this lady, she actually is more than 0.7. What does this tell us is that, meaning to say the quantity is lower than the quality. Okay, so it means basically he's diagnosed to have type 1 von Willebrand disease, because type 1 we know that is the quantity issue. Okay, so but in this patient, back in those days, we didn't proceed with DDAVB trial to know whether patient is a fast clearance or not, but basically she actually have type 1 von Willebrand disease. Okay, so next step is how do we prepare the patient for surgery. Okay, so this is the tricky part, right? Because it's not something commonly encountered in an adult patient. So we need to know that in terms of factor replacement, von Willebrand factor and factor A replacement that's generally few in the market can be plasma derived or recombinant, and the one that we usually have readily available is the alpha-NET. You can see that alpha-NET contains more factor VIII than von Willebrand factor, and generally this is extracted from the alpha-NET website. You can see that for minor or major surgery, and then what is the indication, for example pre-operative or optimization followed by the maintenance. There's two different doses. Okay, so for example, this patient is actually going through this ENT surgery, which can be potentially quite predisposed to bleeding. We are worried. We have classified her as some form of major surgery. So what are the things that we need to do is we choose, for example, alpha-NET. Major surgery is mentioned clearly that pre-operatively we need to give 60 unit per kg of this alpha-NET, and followed by the maintenance dose of 40 to 60 either BD or TDS for 3 to 7 days. Okay, for this patient perhaps we can choose somewhere between TDS for 3 days instead of 7 days, because it's not as major as any like intraperitoneal surgery or even any intracranial surgery. Okay, so this is just a sample of calculation. Patient is weight 53 kg. 1 vial of alpha-NET actually contains about 1000 unit, and it costs about 440 ringgit. This is just an estimated cost. And pre-op, basically if you count by the weight, generally 60 times 50 is about 3000, so you need about 3 vial. So 3000 units is about 3 vial, and you maintain with 3 vial, or you can give BD or TDS for 3 days. So generally the idea is that patient with von Willebrand factor deficiency should have a very good preoperative assessment, and to prepare this factor level replacement before they go for surgery. Okay, so we need to know what is the cumulative dose and what is the cost, because patient need to pay first. The surgery may not be that expensive as compared to the factor that they need to purchase. So let's say total require 21 vial, like 21,000 unit. We also need to calculate the minimum requirement, which is at least if you want to give 60, you give 40, that is about 15 vial, which costs about 7,000. So basically patients should buy this factor replacement first before going for surgery. At least should buy 7,000. Okay, so this is just an idea. Okay, so this case 5 is very interesting case. Encounter this case when back in HKL. It's a 44 years old man who have persistent bruising over the left shoulder after he had sustained a fall, and then he was hit on the door side. Subsequently, the bruises persist, and he went to the ED because of symptomatic anemia with a HB of 4.9 with a macrocytosis, and total Y is slightly elevated with platelet like 400. However, I mean, we are thinking of whether with the abnormal coagulation profile, we are also thinking whether this can be the IVC, but the fibrinogen is actually normal. But look at this coagulation profile. PT and INR is almost normal, just borderlinely affected. But look at the APTT, it's very prolonged. So when we look at this, and patient has spontaneous or even like a massive bleeding after a trauma, then you really need to watch out whether you are dealing with any form of factor issues. Okay, it's a deep tissue bleeding. You're thinking more to coagulation or secondary hemostatic issue. The patient was admitted to the ward. However, patient caught COVID. Patient required ABG, and then because of the COVID era that time, try to minimize blood taking and take from the most probable side. Someone unfortunately poke and puncture the femoral vessel to get the blood, and then patient actually sustained very severe left inguinal hematoma. So this is the patient bruises post fall, which actually persists. You can see that it's very extensive, very extensive until the inguinal into the contralateral side. Just from one single ABG taken from the inguinal region, this whole thing happened. So it's devastating. Okay. So because of this patient have very severe anemia, PBFs is definitely warranted to suggest to actually exclude any form of hemolysis, but generally it's only suggests more to reactive changes. So because of isolated prolonged APTT, the next step, as we discussed earlier, is to proceed with the mixing study. So you can see that mixing study upon baseline is 102. When 1 hour post-mixing is 45, 2 hour post-mixing is 82. Again, it shows that it's the time-dependent inhibition, which is not correctable by mixing study. So next is to check the factor VIII activity as well as the inhibitor. You can see that factor VIII is very low, undetectable, less than 1%. And the factor VIII inhibition is present at the level of 54 petasa unit. That's very high. So when we encounter any patient with acquired hemophilia, we also need to know any potential cause. So we need to screen for autoimmune disease, malignancy, as well as infection. Okay. So the diagnosis at this point in time is definitely acquired hemophilia A, and also complicated with sepsis. So he was started on immunosuppression with the pulse methotrexate and subsequently tapered with prednisolone. He was also started with cyclophosphamide together. However, despite immunosuppression, his hemoglobin levels still persistently dropped and require almost daily transfusion. And the unfortunate thing is that we know that the left groin is already sustained from the big hematoma. Now, the right groin also sustained a spontaneous hematoma intravascularly, and it's actually getting bigger and bigger, measuring 4.2 times 8 times 34, and this is based on CT angiography. Because of this active bleeding, despite immunosuppression, he was immediately started on bypassing agent, which consisted of NOVO7 and also FABA, which is actually the recombinant factor 7 and also the PCC. So unfortunately, we have used up all the quota of this NOVO7 and FABA. We cannot manage this patient. We even use out the pediatric store. So we have to transfer the patient to the Ampang Hemato team for further assessment. It's good to hear that he was discharged well after treated with course of antibiotic and also underwent ultrasound-guided drainage of the infected intramuscular hematoma over the right side. So just to highlight that this is how NOVO7 looks like for the packaging outside, and this is a FABA. When you are fortunate or when you are jona enough, then perhaps you encounter these rare cases and also can be devastating cases. So a little bit information on acquired hemophilia. It's a very rare condition. The prevalence is about 1 in million, okay, in every year. So meaning to say, if you encounter this acquired hemophilia case, perhaps you are lucky because it's like 1 in a 1 million per year kind of prevalence. It's not common, okay? And management generally involves 3 main domains, which is a hemostatic agent to stop the bleeding. We want to eradicate the inhibitors by giving immunosuppression, and the third one is to identify the cause. So how do we give hemostatic agent? This is based on the literature. You can see that you can give recombinant factor 7 and APCC, in which this patient was given both based on the respected doses and then to assess the patient. Okay. So next thing is the inhibitor eradication. Generally, we need to pair the patient with a corticosteroid, like for example, steroid with cyclo or steroid with rituximab. And then if it's failed, then we have to consider second line like mycophenolate, cyclosporine, tacrolimus, or even like other agents. So, and the third domain which I discussed just now is to try to know what's the cause. Most often, the acquired hemophilia triggered by some form of infection or some form of autoimmunity, we can't really identify any obvious cause like any autoimmune or malignancy condition. Most of it is actually idiopathic at the end. So this is the last case. Perhaps we will end our sharing with this case. It's a 27 years old man with a presented with reduced effort tolerance, lethargy, bleeding from the bleeding noted in the urine and also from the stool, and also have gum bleeding. Okay, he presented with a HB of 2.8. That's very super low, with a white cell of 20 and a platelet of 200. The liver function is normal. Urea is actually normal, but the creatinine is elevated. You can look at the coagulation profile. Not surprisingly, now you're dealing with coagulation issue in which the APTT and PT are all prolonged, but the pellet is normal. Okay, so the urgent PBS is definitely warranted with this kind of HB to look for whether there's any evidence of malignancy. However, there is generally leukoerythroplastic picture, but the leukocytosis is suggesting more of reactive changes. So we have transfused the patient. This patient was back in Penang, required multiple transfusion, total 5 pint, and also given vitamin K. However, at day 2 of admission, the coagulopathy is still persistent. This is a repeated coagulation profile and the HB after the transfusion, you can see that the pellet, APTT and INR is still very prolonged. Okay, HB is 6.1. So definitely with this kind of bleeding, gastro is referred, OGDS and colonal is done, just have gastritis but no evidence of bleeding, and had to go back to the patient history to ask whether the patient got any anything fishy from the history. For example, any previous history of bleeding, any family history of bleeding, any traditional medication usage. He did reveal that he has some unprotected sexual partner. However, the hepatitis screening all is negative, including the HIV as well. So because of this desperate situation, we have this patient was referred to hemato team and was urgently given a PCC, subsequently normalized. So when the hemato consultant review this patient, generally we hardly get consultant to see a peripheral cases like in general medical ward. Sometimes when the consultant want to see the patient, meaning to say it can be very interesting or it can be something serious. Like in this patient, we have asked multiple times whether patient have taken any drugs, taken any traditional medication, things like that. He kindly rejected and said no. But when the hemato consultant asked him, the first question is actually not about all that. The first question the hemato consultant asked actually, do you know that anyone tried to kill you? And the patient was really shocked. The patient is really shocked. The reason is being, the patient did not understand why the doctor asked him like that. And subsequently, the hemato consultant asked, if you don't think anyone tried to kill you, do you try to kill yourself? Do you try to take something that's not supposed to be taken? Only then we revealed that he have taken cannabis, or what we call as K2, 1 week prior to the presentation. So with that cannabis usage and with this kind of coagulopathy, the diagnosis is revealed, it's obvious. Okay, it's what we call as most likely we are dealing with drug-induced coagulopathy. So immediately, the hemato consultant give a very interesting diagnosis. Instead of giving drug-induced coagulopathy, the hematological consultant give a diagnosis of bodifacrum poisoning, which is a form of superwarfarin. Why this substance is there is because there's increasing evidence of literature saying that those party drugs, especially cannabis, those that is not properly being processed, or those that sell in the black market or whatever place that you name it, they may contain precipitate to mix with precipitate to actually enhance the cannabis effect. So one of the precipitate they were detected is actually this material called bodifacrum. Bodifacrum is actually a form of superwarfarin. What is superwarfarin? So when we know that in the olden days we are actually using warfarin to kill the rats, okay, the rodent side is actually the warfarin, and this is something similar to rat poison. Okay, bodifacrum is something similar to rat poison, which is a lot of times higher and more potent than a normal warfarin medication. This is called superwarfarin. And when a person is exposed to this, definitely patient will have severe bleeding and severe coagulopathy. However, the management can be reversed very well. Like let's say in this patient was given PCC, and the next day the coagulation profile is normalized, and then subsequently he requested for discharge at own risk, unfortunately. So however, we cannot really confirm the diagnosis by sending a serum bodifacrum level because it's not available in Malaysia. Perhaps in overseas it's readily available. But this is something try to teach us that sometimes we need to know the history well. We need to really ask question. Sometimes the question that they ask may not give you the answer. Sometimes you may need to ask in different angle. You might also need to elicit a more detailed history to know what is happening. Okay, so with that, we will end the sharing today. Just to end with one quote by Paulo Coelho: when we strive to become better than we are, everything around us becomes better too. So I hope that everyone learned something from this a short sharing, almost 1 hour sharing. I hope that everyone will have some idea on how to approach a patient with bleeding disorder. Okay, thank you.